Bom, vamos continuar. Agora vamos continuar com Monika. Monika, que está fresquinha, recém-chegada de São Paulo. Dormiu faz 3 dias que ela está dormindo em avião. Mas muito obrigado por estar aqui novamente com a gente. É a segunda vez que está em Porto Alegre.
É a segunda vez.
E Monika vai ter a função de ser Monika e de ser doutora Larcon. Tem 2 funções. Vai apresentar os dados do St.Jude, Standford, Dana-Farber e também do protocolo. Obrigado. E ela vai decidir em que idioma que ela vai falar.
Olá, boa tarde. Muito obrigada. Eu posso fazer a palestra em espanhol ou pode ser em português, a mim tanto me faz. Em inglês? Ok, vai ser em inglês. So, I will speak in English so that our guests that don't speak Spanish or Portuguese can also have something. And actually my slides are in English this time. Normally they're not, but this time they are because I didn't get a chance to translate them. So, okay. So what I'm going to do is give you a short update about the St.Jude, Standford, Dana-Farber Pediatric Hodgkin Lymphoma Consortium. That's what I've been asked to do. And so I want to give you a little bit of the history. This is the start of a collaboration that started in 1989, and it was a couple of friends, sounds familiar, a couple of friends that were meeting in a bar, and they were thinking there must be a better way to treat Hodgkin lymphoma. And so they decided, they came up with a treatment strategy on a napkin, and it was VAMP, and that's how it started. So the first protocol then came about in 1990, and it was HOD90 with only 2 risk groups. Favorable risk was stage 1 and 2 with no bulk, and they received VAMP and radiation therapy, and an unfavorable risk that got VIPA plus radiation therapy. In 1993, the new protocol, HOD94, was started. Again, only 2 risk groups, favorable and unfavorable, and it was very similar, only that the unfavorable risk received VAMP-COP plus RT. In 1999, it was started with favorable risk, same risk group, VAMP plus RT. However, here, patients that were in complete remission after 2 cycles of VAMP, and we're talking complete remission by CT only, did not get radiation therapy. And then there was an unfavorable risk, which was very unsuccessful. It was VAMP-COP, and it was very bad, so it was stopped prematurely, and instead Standford 5 was started. But let me jump into VAMP real quick. So patients received 2 cycles of VAMP. They had a response assessment, and then they got 2 more cycles of VAMP, and if they were in CR, at early response assessment, they stopped, and if they were not in CR, they got 2550 centigrade. And for the HOD99 study, the low risk was changed actually, and it was not only stage 1 and 2 no bulk, but also only up to 2 nodal lesions and no extra nodal extension. Here in VAMP, the total cumulative doxorubicin dose is actually 200. This is wrong. But you can see that the overall survival and the event-free survival were 89, 91 at 2 years, 89 at 5 years, and the overall survival was 100%. And when we look at whether or not they received radiation therapy, they did exactly the same. So it means that we were able to identify the patients that could be without radiation. And 53% of the patients did not require radiotherapy. However, I want to call your attention to the fact that these were very strict criteria for complete response. And importantly, the patients were cured without alkylators, so there was no risk of infertility in this study. And the patients were cured, actually it was 160, with low-dose anthracycline, so 160 milligrams per meter square. So then, as I said, the unfavorable risk that initially was VAMP-COP was stopped, and we started a new group with Standford 5 plus radiotherapy, and we decided to use the same regimen also for the intermediate risk. And what the patients received is 8 weeks of Standford 5, response assessment, and then they finished with 4 more weeks, so it's a total of 12 weeks of Standford 5. You see the cumulative doses. Doxorubicin is only 150 milligrams per meter square. Even the meclorethamine is only 18 milligrams per meter square, so that it really is only a low risk of infertility in boys. And during a worldwide shortage of nitrogen mustard, we decided to give cyclophosphamide, which sounds familiar. You heard it from Ahopka. And so they received 1,800 milligrams per meter square. For the Standford 5 regimen, everybody got radiation. The sites that were in CR got only 15 gray radiation. The sites that were in less than CR got 2550. And the radiation therapy approach, of course, has changed over time. Initially, involved fields in HOT 99, large fields, and then with certainly overtreatment of some sites. And in HOT 05, we switched to a more tailored approach with a 2-centimeter margin, and no elective nodes were irradiated. So if you had right neck disease, you got right neck radiation and not bilateral neck. What we saw with the Standford 5, and this has not yet been published, but hopefully will be published this year, is that the 5-year event-free survival for all the patients for the unfavorable risk was 80% at 5 years and 86% for the HOT 5 patients. However, as I just told you, some patients had to get cyclophosphamide because of the shortage. Oops. I'm sorry, it goes away. But you can see they did much worse. And so, patients, you see it here, cyclophosphamide. So HOT 5 patients, intermediate risk, the event-free survival with cyclophosphamide was only 72% compared to 96%. 96% for intermediate risk is pretty good. And for the low risk, it was 67 versus 84. So certainly not a home run. But it was horrible during the time of the cyclophosphamide, and when we noticed this, we of course immediately closed the studies. So in 2009, we opened a protocol for favorable risk, and we decided to use Standford 5, 8 weeks with or without radiation, and you see the radiation fields continue to get smaller. So here, I'm sorry, this moved. It was. The response assessment is after 8 weeks, and if you are in CR, no radiation. If less than CR, 2550. And you see
Estão pedindo de fora. Erika de Recife está falando que está escuro.
Mas a diapositiva está escura? Eu que estou escura, mas não precisa me ver. Não interessa. Não interessa. Okay, so here, as you see, the radiation fields continue to get smaller, and I can tell you this trial is ongoing, but we are not irradiating about 80% of the patients. And then in 2013, we opened the new unfavorable risk Hodgkin lymphoma trial, which used we learned from the European OIPA-COP that you have already heard about, and we substituted the vincristine by brentuximab vedotin. Okay, so focus. So you have seen how the Euronet C1 trial is set up. You get 2 cycles of OIPA, early response assessment, and then there was a randomization for COP-DAC, and then RT or no RT, depending on your early response assessment. So based on this study is how we designed our HLHR13 study, only that, as I said, we substituted the vincristine by brentuximab vedotin, and it was given in the same intervals as the vincristine would have been given. And here, patients that were in CR did not get radiation, and those that were in less than CR got 2550 to the site that was not in CR. So this, despite the fact that the patients had extensive disease, they only got this much radiation maybe to the mediastinum or this much radiation to the neck. It was not like in previous studies where they would be getting radiation to everything. Okay, so the primary objective of the study was first to assess the safety and efficacy of 2 cycles of AIPA, but we also wanted to compare the event-free survival with our previous trial, HOT99, and to estimate the number of patients with adequate response compared to the Euronet C1 trial. So this is a collaboration that we're doing with the Euronet, that they are retrospectively doing like a central review and using their response criteria to assess, and hopefully this is also something that will be published this year, and we can see. Other objectives of the trial, we had some pharmacokinetic questions, and those have already been published. We had some immunogenicity questions, and I can tell you that there were no antibodies, so it has already been published together with the pharmacokinetics, but there were no antibodies in our trial in those 16 patients for which this was designed. And then other exploratory objectives were the CD30 density in the Hodgkin-rich Sternberg cells, since we're using a CD30 antibody, and also the soluble CD30 in serum and plasma. And finally, we have collected blood for pharmacogenetic studies that we have left open, so we have not yet decided what to do with it. So from our Hodgkin studies, we have risk-adapted combined modality therapy. These are with prospective evaluation of early response. We have given, or we are given, response-adapted radiation and a prospective evaluation of patterns of failure, and also a prospective evaluation of quality of life that I forgot to mention. And we are incorporating some biological markers. So I am going to give you a peek into our next trial for the Standford Dana-Farber Consortium. And this trial is going to be led by my colleague, Jamie Fleurlage. And what the goal was is to, also what the goal of the consortium is to be novel and innovative, to pilot innovation, to disseminate, to reduce long-term morbidity and mortality, to reduce radiation, not necessarily to eliminate it, and also to improve obesity and metabolic syndrome and the effects of steroids in the population, because at least at St.Jude, the steroids, particularly in the AIPA-CAPDAC, are just too much. We have seen horrible AVN in some of our patients. I had a patient who already had a hip replacement after 2 cycles of OIPA. He wasn't even on trial. He was a low-risk patient that got 2 cycles of OIPA and had got a hip replacement. And so, so we're trying to do something new about that. So how is this umbrella protocol going to look? It's going to be only for classical Hodgkin lymphoma. I think we all agree that lymphocyte predominant is a different entity and needs to be treated differently. It's going to be an umbrella protocol for all the risks, and it will expand on past successes and failures. And it'll be for low risk, intermediate risk, and high risk. So the primary objective will be to evaluate the efficacy, meaning the complete response or adequate response of bendamustine substituting for nitrogen mustard after 8 weeks of Standford 5 in low risk Hodgkin. So we know certainly that cyclophosphamide is not as good as mustard. And of course, we're worried to substitute it again with something else. But we feel that bendamustine is a good alternative because it is a very potent drug for Hodgkin lymphoma. It is cheap drug. It is easily available. We know nitrogen mustard will disappear, and so it's not a strategy that can continue. And we feel that maybe this will be a good alternative. So we want to use the bendamustine for the low risk and for the intermediate risk patients. So it'll be the same exact as it was before, only that here in this case in the intermediate risk we will omit radiation in patients that are in CR and give bendamustine instead for the nitrogen mustard. And then we want to evaluate the efficacy of AIPA after 2 cycles of chemotherapy in high-risk patients with Hodgkin. We are changing the response criteria basically, but we're continuing it. And then, so what we're doing with the traditional Standford 5 is we'll take out the nitrogen mustard, And we will change the prednisone. So the prednisone was through week 12, and then there was here some funky weaning of prednisone for the last 3 weeks. So what we decided for the new protocol is that what we're going to do is we're going to give bendamustine instead of nitrogen mustard. And for patients that are in CR, we will stop the prednisone after 8 weeks. So this does not apply for the low-risk patients because they only get 8 weeks of chemotherapy, but for the intermediate-risk patients, if they have an adequate response after 8 weeks, we will not continue any more prednisone. So this is it. Reduce Standford 5 with bendamustine 8 weeks, and if you are in complete remission, you get no radiation and you're done. And for the intermediate risk, if you are in CR after 8 weeks, you will stop steroids then, but you will continue with 4 more weeks of chemo. And if you're in less than CR, you will continue with the unchanged protocol with the prednisone. And these patients will get radiation. These will not. So why bendamustine is because it combines the alkylating activity of the mustard group with the antimetabolite activity of the purine analog. It is more stable than other nitrogen mustards, resulting in more sustained DNA damage. And at equitoxic concentrations, bendamustine induced more DNA double-strand breaks and more long-lived strand breaks compared to carmustine or cyclophosphamide with low clastogenicity in bone marrow. So we hope that it will be less toxic to the hematopoietic progenitors as well as stem cells. And we also know that it has no cross-resistance with the other cytotoxic drugs like the doxorubicin and the etoposide. And that's how the Standford 5 is built on, that you're giving every week alternating pairs of non-cross-resistant chemotherapy. And also for NHL lymphocytes, bendamustine has demonstrated activity against all cell lines, even those that were cyclophosphamide resistant. So we hope that it'll actually improve, but it'll be very hard to prove any improvement since we don't have all that many patients. But this is, and then for the high-risk patients, for the high-risk patients, what we're doing is, again, 2 cycles of AIPA, early response evaluation. If a patient is in CR, we'll continue the CAPDAC for 4 more cycles, but we will eliminate the prednisone totally. And for the patients that are in less than CR, we will keep the prednisone, and then these patients will get radiation. So why eliminate the prednisone? Because we feel that the prednisone has a role immediately, acutely in the inflammation, but once there is a response, it is not clear that the prednisone really plays a role still on this. So that's what we're doing. Remove steroids from subsequent cycles for all patients in CR. In regards to risk classification, you have seen this table before, I'm pretty sure. So these are the different groups. And right now, we are the ones with the strictest criteria, where low risk is only up to 2 nodal sites. And the truth is, this was based on the original VAN publication, the one that was published by Dr. Donaldson. And what they did is, in this publication that was published in, I forgot exactly, 2006 or 2007, is that if you had more than 2 sites of disease, your outcome was worse. But one thing that was not considered in this publication is that there were a lot of lymphocyte-predominant Hodgkin lymphoma patients, and as you see, they had an EFS of 100, and they probably contributed to most of the patients with 1 or 2 nodal sites, so it was biased towards them. So what we did is we reviewed the study, taking out the LP patients, and the number of sites didn't make a difference. So we are no longer going to do that. And so the new risk classification will eliminate the number of nodal sites for low risk, and this way we are more harmonized with Euronet and COG as well, at least in that regard. In regards to the early response assessment, we are very antiquated because our protocols are still looking at the anatomic and the metabolic response. We have very strict criteria, and so right now, for HLHR13, we want PET negative and more than 75% anatomic response in order to avoid radiation. And we have now learned from our partners in Europe, certainly, and also the previous COG study that we don't need, and the adults, that we don't need to be so strict. So the AHOD 1331 says PET negative is enough, and the Euronet C1 had a 50% volumetric anatomic response, and I think the C2 has no anatomic requirement anymore. So our plan going forward will be a PET response. Deauville 1, 2, 3 will be an adequate metabolic response. However, in regards to anatomic criteria, we haven't yet completely decided if there is certain criteria on the residual disease where we feel that maybe we should radiate. So we're still discussing that with the radiation therapists. And so in conclusion, Standford 5 with bendamustine for low risk, intermediate risk, AIPA-CAPDAC for high risk, reduced cumulative steroid dose, changed risk classification to exclude number of sites for stage 2A in the low risk patients, and changed to PET-only response criteria with possibly an anatomic rule at the end of therapy to decide on radiation. Thank you. Obrigada.
Alguma pergunta? Any questions? No? Christine?
I have only a small question. You talked about your HLHR13 trial and said that pharmacogenetics was already published.
Pharmacokinetics.
Pharmacogenetics, yeah. And
Kinetics.
Yeah, pharmacokinetics were published, but the
Pharmacogeneticity.
I wanted to ask if you think that it is also due to the steroid, to maybe the high amount of steroids.
That's a possibility. Yeah. So we haven't had any patient have a brentuximab reaction. However, we did in those patients, in one or two patients that for whichever reason the chemotherapy got delayed, they had finished their prednisone and they were off steroids. And so yes, it's very possible that that's why.
And again, the hard to spell or to pronounce, but the pharmacokinetics were okay. So you had high levels soon after, and so
yeah, and it also mirrored.
The effect is okay.
As you know, it is a reduced dose. We give only 1.2 milligrams per meter square every week for 3 weeks in OIPA and for 2 weeks in CAPDAC, as opposed to the traditional way of giving it, which is 1.8 milligrams per kilo, not per meter square, per kilogram every 3 weeks. And the pharmacokinetics are very nicely like you would want them to be. Yes.
Any more questions?
Okay. Okay, let's go. Aquí está. No, espérate. Dice.
No veo nada.
Dice Pedro, dice de Alarcón.
Ah, sí, es verdad, yo la puse.
Ahí está. Ok.